Thank you. All right. So I have the privilege of being the current president of ASMBS and first vice president of the Fellowship Council as well, and president of Southwestern Surgical, which probably shouldn't affect this talk at all. These are my disclosures. I don't remember the Boston Scientific Dinner. I don't know what I do with them, but nevertheless, it's on that website. I have to disclose it. This is my other disclosure, is that I do bariatric surgery and I do foregut surgery. And so I live in the little space in between there and do both. So raise your hand if you would self-identify as a bariatric surgeon. Raise your hand if you would self-identify as a foregut surgeon. All right, and how many of you kind of live in the little space in the middle? Some, okay. All right, so, when I think of just in general, the talks leading up to this, like what do foregut surgeons do? You can see the list of things that just sort of come to mind. And then bariatric surgeons, what do they do? And those are the kind of the things that come to mind in my mind as well. So I think it's more symbiotic. I mean, when you think about the relationship between this gator and this bird, he could easily just close his jaws and get a free meal, but he doesn't do that. And why is that? Because the bird eats the decaying flesh between the teeth, and if they didn't allow this to occur, the gator would get a tooth abscess and die a miserable septic death, and knows this. So continues to live like this together. Some may see this as the bariatric surgeon, and some may say this is the foregut surgeon, and you're taking all those cases away and doing bypasses or sleeves or whatever when they didn't need all of those things done. But depending on your perspective, you may say that's the foregut surgeon, and the bariatric surgeon's getting the scraps left over as well. So it just depends on your potential frame of reference. So let's take a case, for example, patient with pathologic reflux after gastric bypass. Even though it's probably one of the best operations we have for it, we do see some patients who still have refractory pathologic reflux after a gastric bypass. So what could be our options in this situation? Foregut surgeon may chip that out, put a links on there, right or wrong. Maybe you could, if they have endoscopic capabilities, maybe radiofrequency energy, strata would be better off. But if a bariatric surgeon saw that patient, that'd be a big complex revisional to either downsize the pouch or resect it and do an EJ, not without some morbidity. So the question is, what was that patient better served? Maybe your foregut colleague could help up in a step-up fashion before swinging for the fence with such a complex operation that it may have significant morbidity. So again, friend or foe. Let's look at another one. What about the patient who presents to your office with pathologic reflux and you happen to notice that their BMI is 55? pH worked up, motility, everything's done, served up on a silver platter for you, and then reviewing the chart and you see the patient's got a BMI of 55. Perhaps some surgeons would still do a fundoplication of sorts or magnetic sphincter augmentation. Personally, I wouldn't, because I think I'll be doing that again in a year from now, I think, when the wrap or whatever's up in the chest. So I think that patient's better served with a gastric bypass at that time. And if you're a foregut surgeon and don't do that, maybe referring that patient to somebody who does do that would be in the best interest of that patient. What about the multi-failed Nissen fundoplication? What do you do here? Some people would tackle it again. Third time's a charm. Tear it all apart, make it do it again. But or maybe tear it all apart, make it look like original anatomy and put the links on. I don't know. But many of us who do both of these operations, fundoplications and gastric bypass, at that point would tear that all apart and convert that patient to a gastric bypass, thinking that was the best operation for that patient now at that time. So I think it's important that we continue to work collaboratively, and this is a multi-year project that's been taking place and spearheaded at SAGES, and looking forward to these final results. But this is a multi-society practice guideline with the variety of societies that you see listed here that have been involved in this project. And I've been involved with this wearing the ASMBS hat for the last couple of years as well. I've read the draft multiple times, and I can tell you, during a search of it, the word bariatric comes up 7 times in the document, and the word faux comes up 0 times in the document, just to let you know. So, bariatric surgeon, friend or foe to the foregut surgeon and that specialty? I'd say it's foe only if it is perceived as such. I do think that we're friends. So in conclusion, I think it's always important, though, to match the right patient to the right procedure and to the right surgeon. Thank you very much.